his comment that we really are here to listen, so I'm going to be very, very brief, which for me, those of you who know, is really exceptional for me to be brief. My wife will tell you that. But I do want to echo what the Admiral said and what Secretary Azar said. The uniqueness is data, tools, and leadership. And I don't want to underestimate how important your leadership, your colleagues' leadership, men and women living with HIV infection's leadership is for us to accomplish what we intend to accomplish together, and that is to bring an end to new HIV infections in this nation such that the epidemic now is over. That is, our term is less than 1 in 100,000 new infections. And I want to echo my colleague's phrase, and we share phrases every now and then. He uses mine that I believe in my heart. Those of you who've heard my life story, particularly with my son's struggle with addiction, that stigma is the enemy of public health. He uses that every now and then. I really mean it. I believe it in every bone in my body. We saw it in the AIDS epidemic. We still have it, particularly for transgender persons and some people in the South, particularly, men who have sex with men. But it's nothing compared to the stigma that we see in our challenges in confronting opiate addiction and addiction in general. I want to echo the comment that Brett says, the Admiral says, is that our goal is to work with the community to come up with innovative plans that are by the community. That's all of you. It's for the community, basically targeted where it needs to be, and it's operationalized in the community. So I don't want you to underestimate. We can do what we can do at our level to try to get the resources, but this program is not going to be successful unless we get full engagement of the community. And the community takes this on as not just the President's initiative, but their initiative to finally, after many, many years, many of us have been in this almost for 4 decades, to work together so that we can have a day where we can finally bring an end to the HIV epidemic. To answer his question directly, very shortly, we're going to work with the community to develop those plans. We're going to work hard to help operationalize and bring diagnosis, as I mentioned in my talk, not just to where we are, but where the people are that needs to be diagnosed. We're going to work hard to bring linkage to care, and we're going to work hard to bring comprehensive prevention strategies. Again, not telling people they got to come to us to get the comprehensive prevention strategy or come to those of you that run these programs, but figure out how to bring them to where people are.
Thank you for your remarks, Dr. Redfield. So now I'd like to introduce Dr. Laura Cheevers, the Associate Administrator of the HIV/AIDS Bureau of HRSA, where she leads the administration of the Ryan White HIV/AIDS program. Dr. Cheever works to increase access to quality HIV care for people with HIV and to integrate services needed to improve health outcome. HRSA's leadership, especially that of Dr. Cheever, will be critical to ensuring this initiative will be successful. Dr. Cheever, can you tell us a little bit about HRSA's role in this initiative and why it's so crucial to the success of the initiative?
Well, thank you all for coming again. I do want to thank you. It is very late, and I hope you all have caffeinated a little bit before arriving here. So the 2 areas that we're going to work on in the Ryan White program first is through the Community Health Center program, which has been a very successful program in working in low-income communities across this country. They're going to be utilized in order to implement PrEP delivery. It's very exciting for us to be able to do that. The programs are well positioned in communities. The health center programs have to have a good community representation on their board, so we think that they're going to be well situated to do that. We've worked very, very closely with CDC, and we continue to work closely with CDC to make sure that as we are working on this project, that at the level of the community, we are working seamlessly together. So it's not that overlap or increased burden as CDC and HRSA are working together. Eugene's nodding, his staff has been up, our staff has been working together to sort of talk through how we would do some of this, because we certainly need to be working with all of you and with CDC to help increase awareness around PrEP in order to provide PrEP in that medical setting, which will be our part of the program there. And there's $50 million set aside next year for the community health centers to do PrEP. So that's the first part. The second part is in the context of the Ryan White program. We are really going to build on the 28 years that we've had of community engagement. Of the 50 counties/cities that we're targeting here or focused on here, 49 of them exist within our Part A communities, within the recipients that we've been funding for many, many years to deliver services at highly impacted cities. In the context of those Part A's, we have a community planning process we've been using for a long time. Also in our Part B's, which are the state programs we fund, we've worked closely with CDC in the last few years to do integrated planning, which means that communities plan from prevention and care in one long sort of continuum rather than two separate plans. We want to build on that work that communities have done. Now we know that in the context of the Ryan White program, we are very successful for the people that walk into our doors. And the challenge of this initiative is to make sure that those newly diagnosed, which have high risk of falling out of care, as we saw in some of the data that's been presented, that we are better linking and retaining the newly diagnosed. In addition, for those people that are out of care in communities that maybe were never linked or were linked and fell out of care, we need to do what we can to get them back engaged in care. And that means that we need to do things differently. The health system failed a lot of these people. It's why they're out of care. So if we're going to link them, it means that we're going to have new partnerships and be working with new people in new ways in order to be able to meet these patients where they are and really get them linked into care and stay in care. So we're really excited about that challenge. We are planning on leveraging the Ryan White program, which means that the planning and the priorities about what's funded and how things get done is going to be done at the local level and the state level. And so we think we've had great success in working with many of you over the years. There are obviously things that we need to be doing differently, and we're looking forward to that new challenge working with all of you. So thank you.
Thank you, Laura. Our next speaker is Rear Admiral Tote, who currently serves as Chief Medical Officer of the Indian Health Service. He's probably one of the leaders of this initiative that you've not heard from yet. So, and he is the IHS lead expert on medical and public health topics and gives technical advice and guidance on American Indian and Alaska Native healthcare policies and issues. He provides national leadership for the clinical and community-based health programs of the agency and serves as the primary liaison and advocate for IHS health professionals. We are privileged to have him join us today. Dr. Tote, will you please tell us about the important role IHS will play in this initiative?
Thank you so much. It's truly an honor to be up here and to be among this panel. For many of you may not know the Indian Health Service. The Indian Health Service is an agency of HHS, and we are the primary agency with the responsibility for providing direct health care and public health services to American Indians and Alaska Natives. At the Indian Health Service, our goal in this initiative is to ensure access to quality health services for American Indians and Alaska Natives living with HIV and those at risk of contracting HIV. We're excited about the President's Ending the HIV Epidemic, a Plan for America initiative, and we're grateful for this opportunity to address HIV in Indian country. In partnership with American Indian and Alaska Native communities, we can end the HIV epidemic in Indian country by strategically focusing our efforts on communities most impacted. With the resources and tools we already have available today, we have an unprecedented opportunity to make a real difference in reducing HIV transmission. Along with NIH, CDC, and HRSA, IHS is a key part of this HHS effort. This plan identifies the counties with the highest number of new HIV diagnoses, the states with the heaviest rural HIV burden, and the territorial area now hardest hit. Some federal, tribal, and urban sites are located in those hotspots. One of those counties is Maricopa County in Arizona, where our HIV Center of Excellence is located. Phoenix Indian Medical Center's HIV Center of Excellence provides medical treatment and care, prevention programs, and research that is specific to the HIV epidemic and its impact on American Indians and Alaska Natives. This center leads a comprehensive approach for the Indian Health Service's HIV care efforts, and we're excited about the President's plan and the opportunities it presents in places like Maricopa County. The President's 2020 budget proposal does include $25 million to establish the Eliminating Hepatitis C and HIV/AIDS in Indian Country initiative to provide treatment and case management services to prevent hepatitis C infection and enhance HIV testing and linkages to care in support of the National Ending HIV Epidemic Initiative. As with any new initiative, we will engage in tribal consultation and urban confer to seek input and work together on implementation and decisions that have an impact to tribes and urban Indian organizations. Since the late 1980s, enormous progress has been made in the fight against HIV. but there's still work to be done. National interventions have driven the number of new HIV infections down to below 40,000 per year, the lowest ever, but not everyone is benefiting equally from these advances. New infections are highly concentrated among men having sex with men, minorities, including American Indians and Alaska Natives, and those who live in the southern United States. And stigma in Native communities can also be a debilitating barrier preventing someone living with HIV or at risk for HIV from receiving the health care, services, and respect they need and deserve. American Indian and Alaska Native, LGBTQ, and Two-Spirit AI/AN people may face culturally based stigma and confidentiality concerns that could limit opportunities for education and HIV testing, especially among those who live in rural communities or on reservations. This initiative will create environments in which all people, no matter of their cultural background or risk profile, feel welcome for prevention and treatment services. I also want to recognize today is National Native HIV/AIDS Awareness Day. It's a day in which we can increase awareness of the impact of HIV/AIDS on American Indians, Alaska Natives, and Native Hawaiians. We remember those who have passed, honor those who continue to advocate for HIV care, treatment, and prevention, and welcome the opportunity for Native people and others to create a greater awareness of the risks of HIV/AIDS to their communities. Today is also a call to action in Native communities to get tested for HIV. So to answer specifically the question on what IHS is best positioned to do, we're really grateful for the partnerships we have with tribes and urban Indian organizations throughout the country. The input and feedback from our tribal and urban partners are an integral part of the continuing efforts of the Indian Health Service and for this national plan. So thank you again for having me here today.
We're going to go right to the questions, but I just want to make it clear that part of this initiative has already started. We've been planning this for months. It was announced at the State of the Union, but in early April, the CDC will be having funding that we've been able to provide from our office, 30 million or so in fiscal year 19 funds to do the community plans and to really establish your network and your leadership so that when fiscal year 2020 comes, we can be ready. Secondly, we now have PACHA, the President's Advisory Committee on HIV/AIDS. Carl Schmidt, one of the co-chairs, is up here in front. I'm sure he's no stranger to any of you. And Dr. Weissman, the State Health Officer from Washington. That's coincident with this. But I think we all know that the proposed initiative, the first year funding of $291 million is proposed in the budget. That money is in none of our banks right now, and we certainly have had great relationships with Congress, but this will depend on the congressional appropriations who have the power of the purse.
So, okay, so we're going to go on and get started. So what we'd like to do is take about 10, 15 minutes to answer a few questions that have been submitted by members, submitted by some of you, or basically people who register for NHPC. And these questions were commonly asked questions. And and then we're going to open the floor up for comments and questions. And when when we come to the floor for comments and questions, what I'd like to do is hear comments or questions from 3 to 4 people before I ask the panel to respond, so that we are as efficient as we can to get as many questions in as we can. Okay? So I'm going to start with the first question that I'm going to direct to you, Dr. Edmund Gerard. And the first question is, how will this plan accomplish the goals while the administration promotes policies that could increase stigma, especially with the LGBTQ and immigrant communities? How do you plan to earn trust from these communities?
So I think all of us, can answer a piece of that question.
Sure.
I'm a doc, I'm a public health person. We're going to do everything we can, starting several weeks ago, moving onward to the future, to make sure every single person is treated with respect. I personally believe everyone deserves care. Everyone deserves the best care that they can get. Stigma is the enemy of public health. And we will, we have here all 4 of us. The Surgeon General is shoulder to shoulder with all of us. And again, we're going to do everything that we can to promote access, availability, no stigma, no discrimination throughout any of our programs. And clearly we're designing this program with open arms. I realize that all of us, maybe not all of us, but some of us need to earn your trust. The trust is a process. It's not just words, it's about what you do. But I think this effort is hopefully a first step to that trust. And we're going to do everything we can to implement that to the best that we can. And that's really what I can say. I mean, that's really what I can say right now. We will do everything we possibly can from the public health side. We take care of everyone equally. I believe that to my core. And as the public health lead for the secretary, that's the way we're going to implement the program.
Would any of the other panelists like to add anything?
The only comment I would add, and I just want to echo what the Admiral said, that I think we believe firmly that everyone's treated with the human dignity they deserve. I want to say one of the reality injustices that still exists that we hope, working with you, we will all correct together, is I think nothing's more unfair in 2019 to be living with HIV infection and not know it. Nothing's more unfair to be living with HIV infection and not getting treatment that we know works. And nothing's more unfair to me to see people who have risked HIV infection and not have the benefit of the evidence-based prevention tools that we know work. And I would hope that one of the things that we'll accomplish together is that we'll create an environment where people do know they're infected, do get the care that they need, are virally suppressed, do get the opportunity to be in comprehensive prevention programs that they feel free to access. Because together we'll work and we'll show that that stigma has no place in this effort that we're going to venture on together.
I think I would just add a few things in that. One is that in the context of the Ryan White program and also the Community Health Center program, we have a great track record in working with all sorts of communities, and we've been able to significantly reduce disparities and have better health outcomes for all sorts of people in the context of both Ryan White and the Community Health Center program. So we are relying on all of you to continue that great work. In the context of Ryan White, we have people living with HIV engaged in planning. We think that's been a really important part of helping to reduce stigma and improve services around the Ryan White program. We plan to continue to do that in this initiative.
And I'll just add, the Indian Health Service works with 573 unique tribes or nations in 37 states, and they speak over 170 different languages or dialects. So we look forward to working very closely with our American Indian and Alaska Native communities. We have to get the voice of the community members, we have to get the voice of the leaders, and we have to create environments in which all people, no matter their cultural background or risk profile, feel welcome for prevention and treatment services.
And I will also say that in addition to having open lines where we had 1,000 people talking to us, I mean, we as a group have met with organizations from the full panoply of the political spectrum. We made it clear, including to very conservative faith-based organizations on day one, that this was a critical public health issue, that they needed to be part of the solution to decrease stigma, because if we have stigma, we're going to have more disease, and that everybody will be treated equally, fairly, and we have to do this as a whole of society approach. If we have segments of society who continue discrimination and who deny access, we're not going to succeed. And so, for what it's worth, this is something that we have started really on day one to meet with everyone, and we want to learn how to do it better.
Thank you. Thank you, each of you. But the second question is a follow-on, actually, to the first. And the second question is, what advice do you have for working in communities where the stigma of HIV and of being gay, bisexual is still very strong? How is this initiative going to address underlying issues of stigma? And I was going to ask Dr. Redfield if he would start with that.
Well, I think the best is, again, we have to do it by example. I mean, again, that's why you all are here. We have to, learn from you. There's a lot of subtleties to stigma. I mean, I've become more aware of it, particularly as I've gone through my own son almost dying from fentanyl with cocaine, and seeing the subtleties that are in stigma as we try to approach behavioral medicine, and the subtleties we do for opioid treatment. I mean, even the term, well, you need to go see a psychiatrist for some people, is very stigmatizing. I'd love to see opioid care integrated into primary medical care the same way we should do for behavioral medical care. So I don't think we have a miracle in it, other than in continuing to learn and look at the subtleties of how we begin to stigmatize, even when we don't intend. The other thing I would ask you all for a lot of help is, and I've looked at a lot of our surveys from CDC, is we need a lot of help to help people not stigmatize themselves. I mean, people need to be proud of who they are, and I do think some stigmatization is self-generated, and you all can be such an important part of helping people move away from that. Communities can stigmatize, or policies can stigmatize, communities can stigmatize, individuals can stigmatize, but I've also seen a lot of people who actually are sort of locked into a degree of internal self-stigmatization. So it's all out. This is again why the Secretary said you all, ultimately it's not the Admiral or myself or Laura as the leaders of Admiral Tawaki. We're not the leaders that are going to make this work ultimately. It's going to be you all in helping create an environment where people can feel proud about who they are, and take full advantage of the wonderful scientific tools that I've been witness to from 1981 to now that have allowed people to live an effective natural lifetime. So it's a challenge, and it needs to be confronted, and it's just going to need to be reiteratively confronted. And Apple's right. One of the first groups we met with is with the faith-based community, and said we needed to be part of the solution, not part of the problem.
Yeah, so thank you for those comments. It is incredibly complicated, stigma. I think there are a couple of things that I think that you all, as you're working on your plans for this, can take on. One is, what is the policy work that needs to be done at the state or local level around criminalization and other things that really are part of that underpinning of stigma? That's something that needs to be done, and a lot of that work is going to be done at the state or local level. And also, we've talked a lot at this conference and other places about you equals you, and I think that has been a really powerful message around that self-stigmatization. So what can we do to really imbue that as people are getting here in other places, where people can understand that having this infection does not need to define absolutely everything about who you are, and that we can really look at it differently. So I think those are like two small things that are two big things that can happen or need to happen, but it's going to be happening once again, both at the federal level as we work, but also as the level as you're working in your communities.
And for the American Indian and Alaska Native communities, we know that stigma and confidentiality concerns can limit opportunities for education and HIV testing. I would say that our most successful approaches certainly involve the ability to share stories, the ability to educate providers in cultural competency and in trauma-informed care, and really in celebrating culture and diversity. We have to create environments in which all people feel welcome for prevention and treatment services.
Thank you.